It's not infection. It's not, people say, is it breast cancer? Is it uterine cancer? No, it's cardiovascular disease. So you need to understand it and talk about it, underdiagnosed, undertreated, and really requires this sex-specific thinking. So the traditional model versus reality. Traditionally, interventionalists like myself, I trained at Texas Heart Institute. I'm the 5th woman to graduate from the Texas Heart Institute, which is amazing. Such a God anointing on me to do the things that I do now. And it's because every door opened. I was trained by J. Willis Hurst at Emory. When I did some work at Emory, he wrote the book, The Heart. So she talks about the book, the physician's death record, but this is the book, The Heart, that everybody learns out of. It's about that thing. And he taught me at Emory before he passed away. And so I've had amazing training. I thank God for it. But I want to take that training and give it to you all, right? And there's nothing like learning and having that something to stand on. Somebody was asking me, right? Are there any papers written about some of these products? I said, yes. All the things that we talk about have serious data behind them, and that's why I talk about it. So fixed obstructive disease meant blockage, like a blockage that we can see. This is an angiogram. So this is an angiogram that looks like there's flow there. So this is a woman who has chest pain, and then the cardiologist take them to the cath lab, and they say, oh, you don't have any blockage, go home. And usually they'll say, oh, it's anxiety, it's blah, 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 right? So it's not, because women have functional ischemia, this CMD, which is where the vessel is not functioning normally and blood is not flowing. So we'll look at that, and it's a dynamic disease. So anatomically and physiologically, women are different. We have smaller coronary arteries and can have diffuse plaquing. So when they do an angiogram, it looks normal because they don't see an actual blockage somewhere. And there's something called positive remodeling. So the guidelines recommend that it's reasonable to assess for this microvascular dysfunction. So coronary microvascular dysfunction means the endothelium or the lining of the vessels not working properly. And many women present with this, and they may have invasive coronary angiography, and it's normal. And their stress test may have been abnormal, but they'll say, well, we can't really find anything, and then go home and here's some anxiety meds. So it's happened again and again and again. So I want you guys to take this knowledge with you to say, no, we're not talking about obstructive disease, we're talking about non-obstructive disease, and we'll look at that in a minute. So hormones in our youth, estrogen supports endothelial function, helps lipids, inflammation, and then comes menopause, right? And it's terrible because blood pressure rises, cholesterol rises, this dysfunction of the endothelium increases, and vascular aging increases. So this is why everywhere I go around the world, women come to me. I have men patients too, but women come to me because they haven't found what's going wrong with them, right? And then we find it because we look at macrocirculation versus microcirculation. So we have in the microcirculation, and that's usually what women present with if they can't, if the doctor didn't find any blockage, where they have reduced coronary flow reserve. Endothelium, or the lining of the arteries, becomes dysfunctional. So the arteries don't dilate. So women may have shortness of breath, or they feel fatigued, or they may not have actual chest pain. And we have to take it seriously, and there's prognostic significance to that. So patients present with angina, with normal angina, right? Shortness of breath, fatigue. HFpEF is heart failure with preserved ejection fraction. So the heart is still working fine, but those small vessels are not filling, and there is the problem. So we can do PET, coronary flow reserve. The resting study can be normal, and the stress study can also look normal. So people who don't look at coronary flow reserve on PET scan, and many doctors' offices will do PET, because it pays a higher reimbursement. They don't know what they're doing because they're not commenting on coronary flow reserve. So if you ever have a PET scan done, ask what is the CFR. If it's less than 2, that means there's dysfunction of the endothelium. Stress CMR, or MRI, basically, stress test using MRI. There will be uniform uptake of what we're looking for in this an outline of the heart. But if there's regional defect, that means epicardial, that means the large vessels may be a problem. But many times it's what we call subendocardial defect. And again, this dysfunction of the endothelium is the problem. So if you know people who have chest pain, women in your circles who have chest pain, say you need to go to a doctor that goes deeper into that, because they can develop heart failure, and nobody knew what was going on. So the notion of this pre-heart failure with preserved ejection fraction syndrome is growing more and more, and more people are talking about it using these tests that I've talked about. And limitations in microvascular flow with limitations in left ventricular relaxation are very prevalent. So I love looking at echocardiogram. I trained with echocardiography, and I would always look at this diastolic dysfunction, or the relaxation delay. Many people don't talk about it, or if they do, they'll report it, but they don't go and work on the patients to cause improvement in the relaxation. Why is that? Because there is vasospasm or microvascular dysfunction. Usually women are presenting like this, and there are some treatments that we'll talk about that can benefit these women, and it's not benign. And most of the time, diastolic dysfunction is poo-pooed away. If you have heart failure where the heart is not working properly, it's squeezing, then, oh, you have heart failure, let's treat that. But you have to think about diastolic dysfunction. So INOCA, ischemia with non-obstructive coronary artery disease. So INOCA, MINOCA, these are new terms that are coming out in the realm of women in heart disease, because ischemia happens, that means there's low blood flow, but there's no obstruction. So what do you do with that? Then you go on to look at PET or MRI, and then get targeted therapy to prevent worsening of that. And that's why a woman who cares about women with heart disease is somebody that people should start listening to. And there are many women in my field who are now talking about this all over the world. At least 4 million Americans have signs and symptoms suggesting ischemia or low blood flow, and they have non-obstructive coronary disease. The WISE study observed a 3% 10-year mortality and 30% adverse outcome rate. That's bad. And those are women who are forgotten. The Warrior trial was a trial of women's ischemia to reduce events in non-obstructive coronary disease. And it was a randomized trial of medical therapy, high-dose statins, ACE inhibitors, to reduce these cardiovascular events. And what they found, they just published this, March 2025, showed that intensive therapy with all these drugs did not significantly reduce 5-year MACE rates, or adverse events, compared to usual care. So we're missing something in medicine, giving all these medications, but not touching the microvascular disease. And that's where many of our products help in that, in decreasing the inflammation. Somebody here is very interested in inflammation, right? But all of us should be, because that's the root cause of illness, especially in vascular disease. All right, so a case of INOCA, or ischemia with non-obstructive coronary disease, 52-year-old female with shortness of breath with exertion. An echocardiogram is very important and shows that diastolic or relaxation delay. So always ask for an echocardiogram, of course, and what is the diastolic function, not just the systolic function. And went for a CAT scan of the coronary arteries, it was normal. So what would happen here to this woman is, usually doctors would say, well, can't find anything, you're okay, let's just keep you on your statins or your blood pressure medicine. And all the while, the heart is dying because it's not getting enough blood because of microvascular ischemia. So a PET coronary flow disorder was done, and it was low, 1.6. So now we know that there's something abnormal with this woman. She definitely has INOCA. So explains her symptoms and predicts her outcomes, and justifies this aggressive prevention. So many of you may be interested in going to OBGYN offices or primary care offices and saying, look, have you heard about INOCA? Ischemia with non-obstructive coronary disease. Well, they may or may not have, and you can educate. So the first thing I think in attracting doctors is educating on something that they may not know about, or they may be struggling with patients in their practice, what to do with them, right? And so you can capture them because our products decrease the inflammatory cascade. There's also something, Takotsubo cardiomyopathy, triggered by stress. I had a patient who went to Spain for the wedding of her daughter or granddaughter, and because of that stress, happiness or sadness, and she was postmenopausal, and suddenly had not a blockage, but there was no flow, and she developed ballooning of her heart, and it became dysfunctional. But it is reversible, right? If it's found early. So the echocardiogram may look normal or may look abnormal, but the symptoms are there. How about pregnancy? I'm just touching on that. Pregnancy history as a cardiovascular risk marker. So pregnancy can bring on cardiomyopathies or weakness of the heart or changes in the vessel flow, where they still have preserved ejection fraction, but they may have microvascular ischemia. So if there's somebody who's pregnant, that's why going to the GYN offices is great, because the OBs will be having these patients who have palpitations, chest pain. So they should be evaluated, at least with echocardiogram. High risk factors are high blood pressure, obesity, menopause, and of course we see this decrease in flow reserve. That means it's not about how the blood is flowing in the big vessels, it's how the blood is flowing in those small vessels that get down to the muscle. That's called coronary flow reserve, and we don't want to see it decreased, which leads to diastolic dysfunction. So diastolic dysfunction is when the heart is relaxing, it gets stiff. And that's the first sign that there's blood flow abnormalities in the heart. So this should be taken very seriously and leads to this heart failure with preserved ejection fraction syndrome. So imaging is great. Statins can help improve coronary flow reserve. Blood pressure control is critical. So we're not saying don't treat with medicine. There are certain medicines that are needed, but there are a lot of the medicines out there that may not be needed or can worsen other things in the body. And of course, no smoking, because smoking causes microvascular dysfunction. And I always tell women, you have really pretty ankles. You want to keep them? Stop smoking. Because peripheral vascular disease comes, we chop the legs off. And that makes people wake up. So here's a clinical pearl: oxidative stress and vascular inflammation. So this is very important for vascular aging. It's a modifiable risk factor for cardiovascular disease. So this lining of the artery, endothelial relaxation and dilation, impairment of that is an early warning sign of arterial aging. So I have a machine in the office that checks that. I was talking to somebody at lunch, said I have something called autonomic nervous system test, and it measures endothelium as well. So that's an easy test to do in the office. And again, these are things that you can teach your doctors in your local region. Endothelial function testing is essential. It's painless. I do it on every patient. And it shows, it kind of leads to the thought, oh, there's oxidation. So oxidative stress is bad. So those are oxygen-free radicals. Everybody has them. As we get older, we have a lot of oxidation and inflammation. Post-COVID, post-vaccine, on. And in autoimmune disease, there's a lot of oxidation and inflammation. What else causes oxidative stress? UV lights, electromagnetic fields, drugs, immune reactions, stress, just stress alone, right? Stress can cause cancer, stress can cause autoimmune disorder, smoking, alcohol. So there are things that people do to themselves, and there are things that are in our world. So what's an important and newly discovered risk factor for vascular aging? It's a determinant factor for cardiovascular disease. It is modifiable. So this is where we should put our focus, our time in decreasing oxidative stress and inflammation. And we talked about the endothelium and why that's so important for blood flow to get anywhere. So, how do we stop diabetes and heart disease? My clinic in Dubai is called Reverse Cardiodiabetes Center. And the same here in the US, I have advanced cardiovascular care with reverse cardiodiabetes as a protocol, all right? So we're using polycosanol. Anybody know where we have polycosanol in our products? So you have to know your product of what you're representing. So Balance has polycosanol, shown to decrease oxidation of LDL, British Clinical Pharmacology 2000. Using phytosterols. What has phytosterols in it? Shown to exert beneficial effects on non-lipid variables such as inflammatory, oxidative stress markers, coagulation or clotting parameters, and the lining of the arteries. That's a beautiful statement. That was in 2019, right? It was way after I started using Balance in patients. So you can stand on, just like, when we're in church, we stand on the word. Well, this is our word for the clinical changing people's lives. The reversal of insulin resistance in the continuum of cardiovascular care. So that's super important to work on insulin resistance. Individuals can protect themselves by getting those receptors to function, decreasing the oxidative stress by using antioxidant treatments to decrease this whole systemic cascade of inflammation. When we use Unicity International's highly acclaimed product, Balance, because it's in the physician's best reference, we can help in the fight against oxidative stress. And this product is a great fiber drink. We know it has so many different flavors, right? I like that pink lemonade flavor that came in one time. And it decreases the glycemic index. So I did a little test on myself. I put the glucose monitor down, long-term 5-day glucose monitor, one of them. There are several brands. And I ate, and my blood, right after eating, blood sugar was like 180 or something. Right after eating. And then I called Jan on this. She's like, what? You need to tell people about this. So after 1 hour, it went down to 120. So it went down 60 points. And, our studies show that. You have all these curves and you see them. But until you see the number on you or you hear about it, you think, wow, this stuff really works. And it does. If they take it, it drops that blood sugar. It reduces glycemic index of foods, lowers the LDL and the triglycerides via this fiber mechanism. It's soluble and insoluble fibers with polycosanol, phytosterols, and polysaccharides. And all of those help in decreasing inflammation and plaque formation. So I get very excited about them because this is what I do every day. This is why I get up in the morning, to change people's lives by reversing the disease. Natural therapy with Balance has been studied, multiple peer-reviewed publications, been shown to have significant benefit in decreasing oxidative stress. So, we of course have to talk about caloric restriction, exercise training, all these things. But if you can eat and take a Balance with it, or right before you eat, and you can drop your blood sugar, why wouldn't people do that? I didn't even do anything. I just sat there and I told my assistants, I said, see, Andy, this is what happens with them, right? Polycosanol and phytosterols are two powerful components in Balance that target oxidation and inflammation and change and protect the vasculature from plaque. So this whole thing means when we stop oxidation or free radicals and inflammation, we're stopping the plaque progression. It's all about the plaque, right? Like the plaque on our teeth, it's not like that. This is like soft and becomes hard and calcified and obstructive and breaks. And when it breaks, soft plaque can break usually and cause heart attack, not severe calcified plaque. Those are more stable. So we want to get the soft plaque out of it. Okay, one in the horizon of prevention, actually external counterpulsation was created 80 years ago. And many doctors do it around the world. I'm part of this International ECP Association for prevention and early treatment of this endothelial dysfunction. So I have women coming for external counterpulsation. They lay on a bed, it squeezes their legs all the way to the buttocks. 45 minutes of treatment is like a massage, and increasing the pressure in the diastolic phase, or the T wave. The EKG shows P, Q, R, S, and T wave, if whoever's clinical in here But in the T wave is where the heart relaxes. So then this blood is pushed into the coronary arteries and grows the coronary, so we can grow new coronary arteries, right? That's very exciting to me. I know that this is a little bit, it's after lunch, and it's hard to understand this stuff, but stay with me. Because if we can increase the blood flow by giving balance, that's what you have in your hand. You can change the world. And you can reverse diabetes. And you can stop people from dying and having strokes and ending up in the nursing home, right? All right. Now these are, so the Unimate, we're talking about GLP-1 effects. So, we all talk about that Unimate helps, it has a GLP-1 agonist effect, but unlike the shot, it doesn't have the side effects of the shots, right, that are out there. So you'll see a lot of people who are on the semaglutide shots. And you can say, well, Dan and I have talked about this. If they're on the shot, okay, fine. Or the doctors have these semaglutide clinics or whatever. You can say, all right, you don't want to keep your patient on that more than 3 to 6 months because of the side effects of pancreatic cancer, thyroid cancer, all these bad things, right? So let them start Unimate because Unimate is so purified that we don't have to worry about those kind of side effects, right? So GLP-1s will help dilate the artery. So will it help this inoca or ischemia, low blood flow? Yes. And helps in multiple other ways. Helps the liver, helps proteins, keeping the kidney from secreting proteins in the diabetic state, decreasing glucose production. So excellent product. So I know you guys are drinking it and you talk about it, but you have to know, well, what does it really do, right? And causes reduced food intake due to satiety or I'm full. Insulin secretion is enhanced from the pancreas. Improved fasting and postprandial glucose, gastric emptying delay. So that's why when we drink it, it's helping with lowering the blood sugar and helping the weight loss. So Unimate improves mental clarity, increases energy levels, lowers appetite, and helps in weight loss. And there are some people, I've met a person who lost 100 pounds using the Unicity Unimate. And I met him like 2 years ago. Increases GLP-1 production. So in yerba mate, so somebody asked me about the mate, is there data about the yerba mate? The chlorogenic acid is similar to coffee and other teas, and it's rich in antioxidants. Remember, we're trying to stop oxidation and inflammation. And it's high in a type of polyphenol called chlorogenic acid. So that's also in coffee and green tea, but chlorogenic acid has huge anti-inflammatory and antibacterial properties. So very important to know what your product has in it so you can talk about it. Theobromine, another compound that Unimate has, it's like a caffeine, but it doesn't have the stimulant effects. And that's why you can drink it and drink it again in the afternoon, and you're feeling great. And it's helping increase energy levels, mood, and mental alertness, focus. So the type of caffeine you have is not causing the jitters, right? That's why you guys love it so much. Mate saponin. These are other naturally occurring compounds in yerba mate, and that causes that bitterness, that taste. And then we talked about the type of caffeine that it has. So this Unimate supports natural GLP-1 production. That's what I want you to remember. So if everybody's on this shot now, right? And I'm not downing it, it's okay. But let's get them to start this while they're on the shot, maybe month number 2, 3, 4, and they can wean down off of the actual injection. GLP-1 is a peptide hormone. It's produced in the intestines and in response to food intake. But this Unimate helps increase the production of GLP-1, and that's how it helps weight management. Okay, key take-home messages, because I know this was a long lecture and it was a lot of big words. But women's heart disease is different. Men usually present with chest pain, tightness after a big meal, it's cold outside, the classic. Women, they don't present like that. Maybe they just can't lift their grandchildren anymore. They can't vacuum, or they just need to sit down more. They're just tired. So that's how women's heart disease presents differently. Usually have normal angiograms, but that is not equal to low risk. you still have to look for that coronary flow reserve. And non-pharmaceutical regimens exist, like what we have, to play a key role in managing this ischemia. Okay, gratitude.